Good morning. I'm Jennifer Shi. I am a physiatrist at Saskatoon City Hospital. My project involved improving the length of stay in stroke rehab. To me, improving length of stay is really about good patient-centered care. At stroke rehab, there's two main reasons why we want to decrease length of stay. Number one is that our patients have a long road to recovery after their stroke. And if we can get them to a level of independence sooner, then we can get them back to living their lives sooner. Number two is that stroke rehab is really the only intervention that's been shown to improve function after stroke. And early access to rehab is critical for best outcomes. So by decreasing length of stay, we can allow earlier access for those who are waiting for rehab and therefore achieve better outcomes. I took a look back at our CIHI data, and I found that our length of stay was longer, yet our stroke patients had poorer functional gains compared to the rest of the country. This clearly was an area for improvement. So as a part of a much larger initiative to improve length of stay at rehab, our team focused on a subgroup of patients who we felt stayed longer because they had difficulties managing their medication safely as a result of their stroke deficits. A retrospective chart review confirmed our suspicions. These patients stayed 10 days longer. So our aim statement was to decrease this subgroup's length of stay from 42 days to 38 days. We had three primary drivers to help achieve our aim. And using a priority matrix, we decided to start with the communication process. Before our PDSA, we took a look at our data from May to December 2019, and we had 40 patients who were having difficulties with medications, but only 35% had documented medication goals. We implemented a simple solution where we added a preset so that medication management goals are flagged on the existing patient goal sheet. And we started a process. So this swim lane diagram outlines the interprofessional roles in identifying the goals as well as communication and documentation around the goals during team conferences. 1 month in, I completed a survey of the stroke interprofessional team, and everyone felt that this process was both easy and useful. And most people felt that it could shorten the length of stay, and the duration of team conference did not increase due to the new process. Unfortunately, since the pandemic, we have had to put this project on hold, so I don't have enough data to tell whether or not the changes we've made have led to an improvement in length of stay. Once we're able to resume the project, our next steps are to fine-tune our prior changes and then to develop a future state process map so that we can have a therapeutic medication management program for our patients to teach them how to take their medication safely prior to discharge. I have learned so much through CQIP, and one highlight for me is the importance of being able to see the problem clearly, because it really helps us make good decisions. Before CQIP, everyone thought that what we needed was a pharmacist so that the pharmacist could run a medication management program. And I just want to show you our fishbone diagram to highlight how complex the problem actually is. If we had only focused on that one component, I feel we would have really missed the mark on the solution. There was a large group of people who were involved with and supported this project, and I would just like to acknowledge their contributions. Thank you.